Alright, hi everyone. Alright, seems to be okay. So, hi Subankar. So, I am Dr. Sourabh. So, we will see this 15 questions for just a sec. Just a sec. Alright. Okay, hi Subankar, Mahek, Monty. So I'm Dr. Sourabh. So let's see this 15 questions in for the upcoming November exam. That is a predictor thing. So I will try to take up the topics and the related questions as well, apart from the questions which have been given already to you. Hi Asa. So let us see, try to solve the first question. So first question is similar to the question which was asked in May exam in INICET in 2025. That in optic neuritis, what is true? First, the most common cause of optic neuritis is multiple sclerosis, and that is a true statement. And that usually causes retrobulbar neuritis. Retrobulbar means the inflammation is behind the eyeball. So most of the times when the patient present to us, there can be the fundus can be optic disc can be normal. That was one of the options. Now the treatment of multiple sclerosis, demyelination, optic neuritis is intravenous steroid. That is a true statement, and that is given initially for 3 days, and after that oral steroids is given for 11 days. So 14 days minimum treatment is given. But the option C, if you see, it's a radio question plus opthal. CT scan of orbit brain is investigation is a false statement, and that is the answer why. Which is true is asked. Okay, fine. If you have to choose one, it should be false. Color vision and contrast are disproportionately affected to vision impairment. That is also a true statement. So the first question should be either it is an INICET question, so there should be A, B, D. These are the true statements. If the question is false, then C is the answer, because C is a false statement. Because which is the investigation of choice for optic neuritis? MRI, because optic nerve is a soft tissue. MRI is the investigation of choice. And why orbit and brain? Orbit will give you optic nerve, and brain because most common cause is multiple sclerosis, which affects brain as well, which causes Dawson fingers, periventricular plaques. So brain involvement is there. And color vision, every sense. I hope you know there are 4 senses in vision: color, contrast, form, and light sense. The vision impairment means form sense. So all the sense are decreased, but color and contrast are more decreased. So after treatment by intravenous steroids, the color and contrast takes more time to regenerate rather than the form sense. Vision comes, form sense is recovered early, color vision and contrast is late recovered. Color and contrast are more decreased. Alright. Now if I ask a similar question in optic neuritis, what happens when the patient has been given a immunization, or there is a viral infection and the patient is having optic neuritis? What is the cause in that? After viral infection or after immunization, if the patient has optic neuritis, which type of optic neuritis is that? That is not retrobulbar, and that is papillitis. Papilla means optic disc involvement. So here optic disc margins are blurred, peripapillary hemorrhages will be there. And if there is optic neuritis and the patient is giving a history of pet at home, cat, that will be cat scratch disease, neuroretinitis, and that will cause a macular star appearance. Now in two conditions we have macular star in ophthalmology. One is unilateral condition neuroretinitis, and the other is which one? Who can tell me? Which is the other condition in which the patient can have bilateral macular star appearance? And what will be the first thing you will do if the patient has bilateral macular star appearance? Good, Subhankar. Bartonella Hensley is the most common cause of neuroretinitis. Bilateral will be hypertensive retinopathy, that is malignant hypertension. The first thing you will do is check the blood pressure, and the only thing you do is control the blood pressure. Okay, so here if the question is which is false, okay, then the answer is C. Good answer. Okay, now the second question is to match the image with the options given. Now this, if you can see, is the image of a photoreceptor. Photoreceptor what? Rod or cone? If you see, this is looking like a cone. So this is a animated picture of a cone cell. And in the cone cell, the nucleus of the rods and cones are in the outer nuclear layer. So B is the outer nuclear layer of the cone. That is option number 2. So 1 is ruled out because it is not a rod. And then C and D are the segments of the cone. Now inner word is towards the vitreous and outer is towards the RP. So this is actually the outer segment. Actually this outer segment determines the shape of the rod and cone. So this is the outer segment. So C is the inner segment. And outer segment was a MCQ, PYQ in INICET. That inner segment is responsible for the homeostasis. It has endoplasmic reticulum, Golgi apparatus, while the option outer segment contains membrane discs. You can see this disc, and disc contains what? It contains the visual pigments, rhodopsin, idopsin. In cone it is idopsin, and this is towards the RP layer. So D is the outer segment, that is 4. C is the inner segment, that is 3. While A is a synapse. In the visual pathway, the impulse is formed in the rods and cones. From here it goes to bipolar via this outer plexiform layer. That is option number 5. So A is 5. So C and D are ruled out. B is 2. So answer is automatically A. C 3 and D 4. Which segment of the rod and cone tells about the shape of the rod and cone? That is outer segment, which contains the membrane discs, that is nothing but the visual pigments. Good answer. The nucleus of the rods and cones are in the outer nuclear layer. Where is the nucleus of bipolar cell, Muller cell, amacrine cell? That is in the inner nuclear layer. So from rods and cones the impulse goes to inner nuclear, from inner nuclear it goes to ganglionic cell, and from here nerve fiber axons, 1.2 million nerve fiber axons, which forms the optic nerve. So that is your second question. Good, Mike. The third is also a retina question. This is the fundus picture given to you, right or left? Just see the image first. There is a right fundus picture given to you, and this is the optic disc. So much blurred optic disc margins. And why right? Because see, the fovea is on the right side of the optic disc. It is a patient which is shown, and all these red are hemorrhages. All red hemorrhages with some yellow, few yellow are these soft exudates, and red are intraretinal hemorrhages, which are flame shaped hemorrhages. So in all the quadrants we have this flame hemorrhages, that is intraretinal hemorrhages, and some yellow things are, these are cotton wool spots, which are also known as soft exudates. Like someone has splashed a tomato. It is an image to be identified in the exam. like a tomato splashed appearance known as central retinal vein occlusion. Why central? Because the entire retina is having problem. If it is a problem in one branch, so one segment will be affected, that is branch retinal vein occlusion. So the question is, most common site of obstruction of CRVO is at. So this is central retinal vein. So artery is ruled out. One, it is central retinal vein occlusion. Artery is ruled out. Not at fovea, at the optic disc. And which part of the optic disc? From where the optic nerve goes outside, that is known as lamina cribrosa. Yes, very good, Subankar. It can cause neovascular glaucoma because it can cause hypoxic retina. Hypoxic retina produces VEGF, VEGF causes new vessels, so it can cause new vessels in the optic disc or elsewhere. Also, it can cause new vessels in the angle of the anterior chamber, which can lead to neovascular glaucoma. It takes 100 days to form this, so 100-day glaucoma is seen in CRVO. Who can tell the management of this patient? Anti-glaucoma drugs is given, yes. But what is the main management? Destroy the entire hypoxic retina. The ocular management is pan-retinal photocoagulation. Plus minus adjuvant will be anti-VEGF injection. The same management which you do for proliferative stage of diabetic retinopathy if there is a new vessels. So A is the answer of this question. So patient will have sudden decreased vision with and the risk factor will be hypertension. Patient will be hypertensive, patient will be old age, because what is the normal arteriovenous ratio? I hope you know in the retina. Normal arteriovenous ratio is a repeat question of INICET 2:3. In hypertension old age it will be 1:3 because artery wall is thick. It can compress the vein and cause venous occlusion. So 1:4 ratio can be there. Tortuous dilated vein can be there in CRVO. Good, so Ankar. PRP is the first and then followed by anti-VEGF injections. Chujitha, Subankar, Mehek, good answers. So that's the third question, CRVO. Now the fourth is also retina. So many retina because see, in November exam in last 2024, out of 15 questions, 8 or 9 questions were of retina. So expect retina questions more. So this is a left fundus image showing some pigmentation in the peripheral retina. Now it is retinitis pigmentosa. One is the image to be identified. Now what is retinitis pigmentosa? It is a dystrophy or a degeneration? It is a dystrophy. It is a dystrophy means inherited conditions affecting rods more than cones, photoreceptors. So dystrophy means it is presenting in young age. And rods are more affected, so night blindness is a feature which is the early feature, not a late feature. Nyctalopia, night blindness is the early feature. Now, if you don't know it is associated with deafness, yes, the most common systemic association of retinitis pigmentosa is the syndrome. Who can answer which syndrome? Usher syndrome. So that is also true statement. So D is wrong because investigation of choice is ERG, yes, but in ERG what happens? There is a wave like this, A wave and B. A represent rods and cones and B represent bipolar and molar. So A wave is the first wave to reduce in pigmentosa. The first wave reduces A wave. The later on B wave can also decrease. And that is the investigation of choice, ERG. EOG, in other hand, electrooculogram. Electrooculogram is the investigation of choice in which there is a Ardens ratio. Ardens ratio normal value is more than 1.85. Who can tell me it is the investigation of choice in which conditions? Condition affect the RPE dystrophy. RPE dystrophy means one is Best and Stargardt's dystrophy. And there is no treatment of any dystrophy. In pigmentosa, 2 vitamins can be given, one vitamin A and docoxahexanoic acid to decrease the progression. Otherwise, there is no definite treatment of any dystrophy. Okay, let me ask you another question based on this INICET level. If the patient of retinitis pigmentosa come to you and he has polydactyly, multiple fingers, polydactyly, then what is the answer? Which syndrome? So various systemic associations can be there in pigmentosa. Most common is ushers. For example, a patient is having your A beta lipoproteinemia. Nice, Subhankar. Scrambled egg appearance. Yeah, Bartle-Biddle syndrome is the one which our answer is polydactyly. So similarly, the patient can have A beta lipoproteinemia also associated. Various systemic syndromes are associated. Most common Kane-Sayre syndrome can be associated. Most common is Usher syndrome. Bartle-Biddle was the answer, polydactyly. Now test to study the blood vessels of the retina and choroid. Now there was a question, test to know the layers of the retina in vivo. For the layers of the retina, particularly central retina, that is optical coherence tomography. Perimetry tells about the function of the retina. Why? Because it tells about the visual fields, and visual field is all because of retina. Ultrasound can be A and B scan. A scan tells about the axial length of the eye, which is useful before cataract surgery, and B scan is used for posterior segment or eye evaluation when there is a media opacity. Angiography, fluorescein angiography tells about the blood vessels of the retina and choroid. There is another angiography which particularly tells about the choroid. Which one? Which tells only about the choroid, not about the retina. That is indocyanine green angiography. Now why indocyanine green and fluorescein are used? Because they have a property of fluorescence. Low wavelength come inside, they emit higher wavelength. So if the low wavelength comes inside in fluorescein, that is a blue wavelength, green is emitted out. That is the property of fluorescence, low inside, green outside. Indocyanine 810 nanometers comes inside, 840 goes outside. But that is very bound to protein, so it does not cross the blood ocular barrier, blood retinal barrier. So it is better for occult choroidal pathologies. Occult means chupi hui. For hidden choroidal pathologies, ICG is better. Otherwise, for both retina and choroid, fluorescein is the maximum question asked in the exam. The next question is a binocular vision question. A similar question was asked in NEET exam. What is the test being done over here? The patient is wearing some red-green goggles. 4 dots are shown. The name of the test is Worth 4-dot test. Now it is a test for binocularity, test for suppression. Why binocularity? Because both eyes are open. And the answer is, which of the following represents the left eye? Left eye suppression means left is not working. So actually this left eye can see only green color because of the green goggles. Right eye can see only red color. 4 dots are shown. A normal person will see all the 4 dots. The 4th dot will be seen as a mixture of red and green. Take it as an orange maybe. But 4 dots. So this is normal. This is normal representation. If 2 dots are seen, red dots means right is functioning, left is suppression. So that is the answer of this question, C. Good. And if 3 green dots are seen, it means the right eye is not working. That is known as right suppression. Let me see who can answer the interpretation of the option number this E. Who can tell me? Worth, I'll give you a hint. Worth made such a test that if diplopia is there, then 5 dots will be seen, not 8. Who can answer? This patient is having with squint. Esotropia, exotropia, esophoria, exophoria, what? Eso or exo? This is uncrossed diplopia or crossed diplopia? So always Worth 4-dot test, Maddox rod and visual field are represented as patient's view. So if the patient, you are the patient who are wearing right goggles and saying right, red is on the right side, green is on the left side. So this is uncrossed diplopia. Very good. And uncrossed is seen in ESO squints. Very good answer. So it is a subjective objective test. It is a subjective test because patient tells whether he is able to see or not. All of the following are seen in this picture. This is also patient having squint. Why? Because right eye is looking straight. This is patient. Right eye looking straight. Left is not looking straight. It is going down and out. So down is known as hypotropia. That is true. Out is known as exotropia. So there is hypotropia and exotropia. So answer is clearly which of the following seen except ESO is the answer. It is not ESO, it is exo. And aniso means difference, chorea means pupil. See, the difference of few pupils are there, so anisochorea is there. What is happening here? This is patient having left which nerve palsy? Hypotropia, exotropia, plus there is a ptosis. Now, if there is a ptosis with squint, it has to be third nerve palsy. Third nerve supply all muscles except SO and LR. So, SO causes the eye to go down, LR causes the eye to go out with ptosis. Third nerve is a constrictor of the pupil. So, there is a dilated pupil as well, anisochorea. This anisochorea you can tell is more in which light conditions? More in bright light or dark in this condition? More in bright light condition. Why? Because in dark what happens? The right pupil will also dilate and anisochorea won't be seen. In light it is not able to constrict. And there is no diplopia when the patient looks on levo depression means left and down. That's why the both eye will be parallel. There is no diplopia in left third nerve palsy in levo depression. So answer is A. So who can tell me why this picture is not AD's pupil? What are the features differentiating AD's pupil from third nerve palsy? What is AD's pupil? AD's pupil when there is a lesion in ciliary ganglion. That is also constricting pupil. So there is also dilated pupil, more in bright light, there is an anisochorea. But why this is not AD's pupil? Because in AD's pupil there is no ptosis and squint. Third nerve supplies LPS and muscles. AD's ciliary ganglion supplies only the pupils. So there is an anisochorea like third nerve palsy but no squint and ptosis. And what is the test? There is a diluted, what will happen if I put a diluted pilocarpine? Diluted means 0.125% pilocarpine in a patient of AD's pupil. If I put in AD's pupil, the pupil will constrict because of supersensitivity. But if I put in third nerve palsy, pupil will not constrict. Even a normal pupil will not constrict because 1% is minimal required for constricting a normal pupil. Diluted pilocarpine can constrict only one pupil in the entire world, that is AD's pupil, because of supersensitivity. Hence, it's a diagnostic test. Now, picture is being shown. Is given that in cataract surgery, intraocular lens and sutures are used, and a picture is being given. Some sutures are being put over here. Now, who can tell me which surgery might it be there? Of course, it can be any cataract surgery, but if so many sutures are there, it might be a long incision one, maybe extra, and it is at the limbus. So mostly it is an extracapsular cataract extraction being done, and the sutures used are nylon sutures. So nylon is the answer, so C and D option are ruled out. So what is A and B? Macquarie coffin and hydrogel. What is that? Intraocular lens is not made of. Macquarie coffin is a corneal storage medium that is used in keratoplasties. One material of intraocular lens is hydrogel material. So hydrogel is a foldable or non-foldable material. So intraocular lens can be foldable, can be non-foldable. Three examples of foldable intraocular lens are acrylic, one hydrogel, which is option number 2, and silicone. While one example of a non-foldable one, which makes a hard contact lens as well, that is polymethyl methacrylate. Sutures in cornea and cornea sclera sutures are nylon. In eyelids, the sutures are used are silk. For conjunctiva closure, the sutures used are generally vicryl, which is absorbable one out of these nylon, silk, vicryl. Vicryl is an absorbable one, silk and nylon are non-absorbable one. Good, Subankar. Now this is an easy question, has been asked multiple times but frequently asked. A patient visits emergency with a history of blunt trauma in the following radiological image. What is the image showing? CT scan, MRI, X-ray. Bone is there, so there is a CT scan. CT scan is showing this is right, this is left. Left eye pathology. The inferior wall of the orbit is having fracture. This floor fracture is given the name blowout fracture. Who can tell me which bone fracture? Which is the weakest wall of the orbit? Maxilla. Posterior middle aspect of maxilla. Which trauma? Blunt trauma. It will lead to which squint? Restrictive squint, paralytic squint. Here the inferior rectus muscle get entrapped, and entrapped means restrictive squint. So if the IR muscle is entrapped, the patient will have difficulty in looking up or down. Up, because it is a restrictive squint, it's not paralytic squint. If IR is palsy, then the patient has difficulty looking down. And so if someone boxes you, the eyeball goes inside. Inside is known as N-ophthalmos. It is a true N-ophthalmos. Who can tell me in restrictive squint what happens to the force reduction test? Positive or negative? Good, Savankar. Force reduction test is positive test because you will feel the restriction. That is a positive test. Alright. Infraorbital nerve is also anesthesia because that passes to inferior orbital fissure, that is in the floor. Okay. Another trauma. See, trauma question is the one should be asked. One trauma question, injury question. Chemical injury, maybe traumatic injury, maybe radiation injury. So here a 45-year-old patient presented after blunt trauma with eye examination, and the patient has deep antechamber and jet black pupil and blunt trauma. These are the three things given to you. What can be the answer? Blunt trauma can lead to all of the following, true or false? True. It can cause the lens to go anterior, posterior, yes. It can cause Berlin's edema. Berlin's edema can cause, that is cherry red spot, ganglionic layer edema. But that is not answered because it is not leading to jet black pupil and deep antechamber. Jet black pupil means there is no lens in the patellar fossa. That is causing deep antechamber as well. And you can see the pupil now. That's why anterior dislocation is ruled out. So answer is posterior dislocation. Yeah, hello amigo, I'm sorry about that. See the people now. That's why anterior dislocation is ruled out. So what are the things? What are the three things which goes in favor of vitreous hemorrhage in the question? If the patient is having vitreous hemorrhage, they will give you first floater symptom. Anything in the vitreous pathology, vitreous has something blood or pigment, it will have floaters. Second, they will give you the patient can have sudden decreased vision. And third, the red glow which is seen in the pupil, that will be either dark or not seen. Dark or no glow in the pupil, that is coming, the red glow coming from the retina is not seen because something is before the retina, that is the blood. So floater, sudden decreased vision and a dark glow goes in favor of vitreous hemorrhage. Berlin edema differential is cherry red spot. Which layer is involved in cherry red spot? Ganglion layer. And differential of cherry red spot you should know. Ganglionic layer edema can also be seen in one more condition, in which the patient has a rheumatic heart disease, maybe arrhythmias, cardiac arrhythmias, rheumatic heart disease, sudden decreased vision, transiently, amaurosis fugax. What is that? CRA or CRVO? So if the patient is having history of rheumatic heart disease, means that is embolus, or cardiac arrhythmia, that is embolus, that is central retinal artery occlusion, which will have amaurosis fugax, that is transient blindness, because embolus can dislodge, vision can come back within 24 hours, that is central retinal artery occlusion, amaurosis frigox. But if there is a superior or inferior visual field defect with a patient of rheumatic heart disease, there will be branch retinal vein occlusion, because one quadrant will be having edema. Holland-House plaque is the most common embolus. Yes, cholesterol embolus. No, visual field charting is perimetry. It is a subjective objective test. It is a subjective test, so it is wrong. Patient will tell he is seeing or not. It is a subjective test. Always when the visual field is given to you, it is taken as patient's view. Patient view means, for example, I am drawing a visual field for you. This is right side visual field. This is superior, this is nasal, this is temporal, this is inferior. And in the temporal side there is a blind spot. That is true because the optic disc is nasal in the retina. So B is the answer, true. Maximum visual field is in the temporal because there is no obstruction over there. Minimum is superior and nasal. And it can be determined bedside. That is known as confrontation test. Confrontation test is a bedside perimetry. Who can tell me confrontation is example of kinetic perimetry or static perimetry? If the stimulus moves, it is a kinetic perimetry. So confrontation, stimulus moves, it is a kinetic perimetry used for neurological disorders, not glaucoma. In glaucoma, we use a static perimetry, that is a Humphrey static perimetry, in which the stimulus does not move, the intensity keeps on changing. Multiple intensities, multiple stimulus are given, patient is given a trigger. If the patient sees, he presses the trigger. That is also subjective. Every visual field is a subjective test, not objective. So B is the answer of this question. Kinetic preferred in neurological disorders, static preferred in glaucoma. Now, routine examination of a 70-year-old patient, you find multiple mid-peripheral yellowish flecks in both eyes. Only two things are given. One is age and this flex word is given. Deep knowledge of the subject will give you that flex is nothing but lipofuscin that is deposited in two conditions. One is Stargardt's and one is best. And lipofuscin like a flex. Flex means scattered. Scattered goes in favor of a beaten bronze appearance, and that is Stargardt's. So Stargardt's disease is a RPE layer dystrophy, where symptoms are more, signs are less. In contrast, best has more signs, less symptom. I just told you electroretinogram is A wave and B wave. RPE is not involved in A and B means rods and cones are not involved in Stargardt's. So ERG is normal in Stargardt's, and that is the question. That is the answer. EOG is decreased in later stages. Electrooclogram is decreased. And autofluorescence reveal dark choroid is seen. That is true. But dark choroid is seen on angiography, not on autofluorescence. Autofluorescence will tell you about the lipofuscin deposit everywhere in the retina that is scattered like a flex. Explorer guy, this is not the time to answer this clinical question. Refractive surgery, please tell me, message me. Even in message I won't be able to tell, because refractive surgery which is good for you for minus 9.75 SMILE or LASIK should be told by the concerned doctor by which you are seeing, depending on the cornea thickness, depending on so many other things. So on measure or message, it is not a good thing to ask, and particularly not in the INICET predictor, because that is not going to be asked in your. Ajay, you tell me, Explorer guy, INICET question. A boxer comes to you, 22-year-old boxer comes to you, and he want to get rid of glasses, like you want to get rid of glasses, which is absolute contraindication in a boxer. Which refractive surgery is absolutely contraindicated? Answer is radial keratotomy, which is relatively contraindicated. Answer is which you gave, LASIK or SMILE. LASIK is relatively because that has flap can dislocate. So explorer guy, if you are a boxer, the only option left for you is smile, but that also depends on the cornea thickness. If that is not eligible, then who can tell me what am I drawing? Which refractive surgery am I drawing over here? Tell me. Explorer guy is a young patient. We don't take out the lens. We put an extra lens over here. What is the surgery known as? This is known as phakic IOL. Phakic means the patient has lens and we put in extra intraocular lens in the sulcus between the iris and the lens. One example is ICL. ICL is implantable Coulomber lens. Okay? So get and check from your doctor which is suitable for you. So this answer is Stargardt's disease. Good enough, good answer. Yeah, explorer guy, thank you very much. You know the answer very good. Now tell me, explorer guy, what is being shown? This visual field is being shown. True regarding visual field or obvious. You have to see the false statement. Always a visual field is given as a patient's view. So this is the right, given to you it is a right visual field, given to you it is a left visual field. You can see carefully. Who can tell me what is this? This is your right visual field blind spot due to optic disc, always in the temporal field because optic disc is in the nasal field. So this is bilateral visual field defect and both left side visual field defect are, so it is left homonymous. Homonymous means same side. One is 50% involved, other is less than 50, that is known as incongruous. Now left visual field has hemianopia but incomplete hemianopia, that is a true statement. The right visual field has complete hemianopia. Hemianopia means half and complete means total 50% involved. Why is D the answer? Because that is seen in right side optic tract lesion. If the lesion is on the right side behind the chiasma, then it has to be left homonymous. Always remember, if this is a top view, the lesion is over here behind the chiasma on the right side, right optic tract, LGB, radiations, cortex, it has to be left homonymous. So right optic tract lesion will have left homonymous. Here it can be congruous and can be incongruous. Small lesion can be incongruous, large can be congruous. Only heteronymous seen Suvankar in optic chiasma lesion. Optic chiasma will have heteronymous hemianopia. Multiple times a very easy question, but I will ask other question also based on this. What is being done over here? This device is for measurement of proptosis and that is known as exophthalmometer. Which one? What is the name of the device? Hertel's exophthalmometer for proptosis. What is the most common cause of unilateral bilateral proptosis in adults? Thyroid eye disease. Most common cause of unilateral proptosis in children, orbital cellulitis. Most common cause of bilateral proptosis in children, neuroblastoma. Exophthalmos word is same as for proptosis but for thyroid eye disease. Thyroid eye disease is HL mediated, true or false? True. Same antigen as thyroid as in orbit, true. Inflammation in the orbit, true. The features are due to glycosaminoglycan deposition in the orbit, true. Werner gave a no specs clinical features, true. Can there be vision decrease? Yes. NOSPECS. S means sight loss, vision loss. What is the reason of vision loss in thyroid eye disease? 1C, corneal exposure. If there is eyeball is coming out, cornea is exposed. Second, optic nerve compression. Who can tell me optic nerve compression can be tested by? Which test? If there is optic nerve compression or optic neuritis, what is the first sign of optic neuritis or optic nerve compression? Hint. Swinging flashlight examination, Marcus gun pupil, relative afferent pupillary defect. If you swing the light to the abnormal side, pupil will dilate because of paradox. That is Marcus gun pupil. Who can tell me complete optic nerve lesion leads to which pupil? Amarotic pupil. ED's pupil due to ciliary ganglion lesion, I told you. A patient of neurosyphilis comes to you, sexually transmitted disease comes to you. Near reflex is present, light reflex is absent. Where is the lesion? Neurosyphilis, light reflex absent, near present. pretectal lesion. Argyle Robertson pupil. Now child come to OPD with a prescribed of -2 diopter spherical with -1 cylinder at 180. What is the refractive error of this patient? Without pen paper. You don't get pen paper. I am also not doing. Let us do this question without pen paper. -2 spherical means it is working in all the axes. We have two axes, vertical, horizontal. So -2 is working in both. And -1 cylinder at 180 means it is kept at 180. But cylinder property is when it is kept at 180, it works always 90 degree to where it is kept. So vertical become -3, horizontal -2. Both minus means you are giving minus means both rays should be focused in front of the retina. That's why you are giving -2 diverge. So that is compound myopic astigmatism, and that's the only option, B option. Even if you don't know with the rule against the rule, does not matter. The answer is B because the both axes are in front. How do you solve this? -2 like this. -1 cylinder kept here, working in the vertical. So it becomes -3 in the vertical, -2 in horizontal. Both minus means both are in front of the retina. Now who can tell me why it is with the rule? Because -3 is more in front because you have to diverge it more. And -3 is in vertical axis. So -3 is steeper axis. By definition, vertical steeper is known as with the rule astigmatism. This one, B is the answer, not C. Alright, how many questions have you got correct out of 15? Yeah, horizontal steeper is against the rule, vertical steeper with the rule. How many questions have you got correct out of 15? And if you want to know some other topics, I have 5-10 minutes more in my session. Let me know. Good. 13 or 12 above is a good number. Good, Himali, Mehak, Subankar. There is 1, 2 more should be a good number. 12 above is a good number. Anything you want me to tell you in 5-10 minutes? Yeah, Mehak, it will come soon. Already in the printing stage. A nephrology book. Right now concentrate on giving the INICET exam. Herring's law, AI is working in both eyes first thing. And Herring's law tell about yoke muscles. Now whenever there is a squint question, I always say squint question can be solved by making a cross like this. This is a patient standing in front of you. This is the right eye, this is the left eye. This is LR, MR because they work only in the horizontal axis. Now which muscle should come here? Which muscle is the elevator in abducted position of the eye? That is SR. Depressor in abducted position IR. Depressor in adducted position SO. And elevator in adducted position IIO. So this will make your life simple, this line diagram, because Herring said that the patient does dextroversion. Dextroversion means both eyes are on the right side. So see this one and this one are the yoke muscles working. In dextro elevation, right SR and left IO will work. Corresponding muscles are yoke muscles told by Herrings. Levo depression, left and down. Left IR and right SO, these are the yoke muscles working in levo depression. And actually when there is a paralytic squint, you can solve this question like this. Whenever there is a paralytic squint, the diplopia is maximum in the direction of the muscle working. Like in left IR palsy or right SO palsy, in levo depression there is maximum diplopia, means left and down. Left and down there is maximum diplopia in right SO and left IR palsy. Similarly, if the patient is right SR palsy or left IO palsy, he is having maximum diplopia in dextro elevation position, means right and up, in the direction of the paralyzed muscle. That is the way of solving Herring's law and diplopia question also in parallel squint. All right. All right. Chalo. Thank you very much. Thanks for listening and best wishes for the upcoming exam of INICET. Best of luck.